Hi everybody, I'm Libby Hopkins. I am a volunteer here. One of my roles is volunteer trainer. I have a number of years in the world of death and dying. I've been a nurse for 42 years, and the last 21 or so of those years has been in hospice and palliative care. My first years in psych and mental health also included some grief and loss work at UNMH. So I was already kind of on my way to knowing where my place really was, and I could still use my psych mental health skills. So I have a bachelor's degree in nursing. My master's is not related, it is in organizational management, but my postmaster's certificate is in applied thanatology, which is the study of death, dying, and mourning. I'm also a certified hospice and palliative care nurse, a certified hospice and palliative care administrator. And my career has been senior leadership, founding, hospice consulting, back to the bedside, week on, week off, night on call, and that's how I kind of survived financially by doing the management work, and I love education. I don't love a lot of the rest of management. I don't like money management, but that allowed me to then go back to the bedside where my heart is. So I'm now semi-retired, and I am here to give you really the basics of symptom management. Please understand that I don't expect anybody to memorize any of this. There's an orientation checklist that Miles will give you, or Rosa. All of those things you're going to look at and go, oh, you don't need to know all of those, and we aren't checking them off when you've been told. That doesn't work. You are checking those things off when you have actually reviewed them and done them a few times and feel comfortable doing them. So don't leave and go, oh, I think she mentioned that. This is about you and your comfort level. And so I think it might be, if you don't have one, it might be that Miles is grabbing those now. There's also a pre-test that we won't worry about because we started already, but if you'll do an evaluation afterwards, including Kathy, if you feel up to it, would be fabulous. We're going to begin. Right here is my card. If you want to copy that, that's fine. I also have a few other credentials. I'm a yoga instructor, and my specialties are adaptive, restorative, and chair yoga. I'm also a cannabis establishment technician, believe it or not. So
when you're semi-retired, that means you only work 80 hours a week?
yeah. Well, 60 to 70, but I'm working on it. I'm really working on it. Yes, I'm working on sharing some accountabilities. But right here, if you'd like to take a photo, is my phone number. Obviously, Miles is your executive director, and Rosa is your program director. Chef Kenny, Tori's your president of the board. Obviously, you're going to go to them first, but if you have a really clinical question, then feel free to give me a call. If it doesn't have to do with processes or anything like that, you're in the house. So, it's probably going to be easier for you to follow along on the booklet than it is here, but we'll continue to move these up. So, as we start, every death is different. So, see, handwritten stuff on the contents, yep. And okay, and I don't have the pages listed right. Anyway, every death is different, so you won't find it. There's certain things that most people who die have in common, though every death is completely different. And as I go through these symptoms, I want to say that some people have all, some people have none, and most people have some. Okay, but these are very typical. There are some more specific ones we'll talk about, but many of them are typical, whether it's cancer, lung disease, dementia, many of these same signs of approaching death are the same. So, symptom management of our guests, physical, emotional, psychosocial, spiritual, it is the greatest gift that we can give them. And it's really important for you to know that there is only one chance for good death. I want you to know also that not every death is a good death. Most deaths in hospice are good deaths, okay? But I want everyone to know that, just so you understand that there are times when if we do everything we can, there's still some discomfort, and I don't want you to think it is your fault, because even the most skilled, if there are unusual symptoms, may not be perfect. We do the best we can, and we do it with love, right? So, another thing I want to tell you is if somebody has symptoms, and let's say it's 6 in the morning, oh, just wait till Miles gets here and they can call the hospice. And you've done everything you can, and we're going to teach you what to do. You won't have to memorize it all, but when you've used all the tools that you have, and it's 6 a.m., you're going to call Miles anyway, and you're going to ask him to call the hospice, because there is one chance for a good death. And let's say you just wait, and then the hospice nurse is an IDG and doesn't get here, or doesn't give any verbal orders. A lot of times it's verbal orders, which is why Miles will take those orders. Because if we lose that guest in that 2 hours, because we were trying to be nice, or we're nervous about it, or we're not sure if we should be calling or not, always err on the side. And when I say call hospice, I mean call Miles to call hospice, or Rosa, or me if I'm here. But just don't take, or if it's, sometimes in fact somebody will ask, and we won't be sure if they're gone, and we don't know. Call. Always okay to call. I was a night on-call nurse for 7 years of my hospice career, and I will tell you that it was so appreciated when people went ahead and called at the moment they didn't have any more tools, or the moment they suspected that there was a problem, instead of waiting. So it's not a kindness to hospice to do that. That's why we're there in hospice. Early signs, yes.
So
Go ahead.
a bad death is when symptoms are, when there's pain or anxiety, or if
Yes, and
patient
you've used your tools, you'll be learning all the medications, you'll be learning how to know what the prescriptions mean, you'll be learning all the non-pharmacologic interventions, which are critical, elevating the head of the bed, all of those things that we'll go through. And you've done those things, and we expect to need to do those things, that's why we're here. But we've done them, and it isn't working immediately.
But, so we're talking about physical symptoms. What about
Yes.
spiritual
Yep.
problems or emotional
So there
problems?
is the hospice team consists of the attending physician or provider, the hospice nurse, the hospice chaplain, the hospice social worker, the hospice volunteer, the hospice bath and care aide. I think I named them all. And so sometimes some smaller hospices have only a social worker, only a chaplain on call in the middle of the night, so you might only get one another. During business hours, they're both, and even if, let's say, somebody has declined chaplaincy, but we need their help in the middle of the night. It doesn't matter if they've declined that, yet. It doesn't matter if it's their first visit, it doesn't matter. Or the family, a lot of times, will like to have the chaplain. And so, sometimes when the hospice nurse comes to pronounce the death, all of our residents, all of our guests are on hospice. They have to be on hospice because we are a social model, we are not a medical model. So we don't have a medical director, we don't have nurses. Those of us who are nurses, it's merely coincidence, that is not nurse scope of practice. When we're volunteers here, we take our orders from hospice, and all of those services are provided by hospice, as are things like hospital beds. These beds are, I don't know, Kathy, what do you think of the bed? The hospital bed.
It's okay.
Okay. So, thank you for that feedback. Miles and Rosa know I'm gonna say this. We love having our own stuff that's donated, and our mission is to provide everything. People, however, pay for the hospice benefit by paying into Medicare. It's free, but believe me, everybody has paid to get this benefit, and part of the benefit is a hospital bed. And so, I am encouraging strongly that we allow hospice to bring in their beds. They're not perfect, but they're much better, and the things that we can add to them, we can add a few things, like a blow-up mattress to these beds, but the more sophisticated things, if somebody is completely bed-bound, and most of our individuals are, things that are much more sophisticated can go on those beds too, and the rails go higher. So, also, since we're on hospice benefit, we'll just finish that topic. Well, it's never finished, but I'll add to that topic, is that people who are on hospice have the benefit for their loved ones, and loved ones can be spouse, family, friends, caregivers. You know, if somebody's lived in a facility, if somebody's had a home caregiver, it doesn't have to be family or friends. Anyone who has cared for or loved the individual is entitled for 13 months to brief counseling. So, what does that mean? It means a lot of things. It can mean visits at your home. It can mean video visits. It can mean support group. It can mean nothing but literature, things to read monthly. And it's always individualized. If the loved one is out of town, either they can have services from their hospice here remotely, or they can be referred. We have to take, I say we as in hospice, not we as in Inhora, have to provide those services for other hospices or anyone in the community. So the bereavement counselor, that's the other person I left out. She's the one who, and sometimes it's the same person as the chaplain or the social worker, because those are great credentials. As we get those services, the bereavement services, the person here will call if they want in-person services or support group, call whatever community and connect with the hospice or a grief support service there. So it is for everybody, not just those who are local or related. Okay, the other thing I didn't say that they supply, medical equipment. They have overbed tables, wheelchairs, walkers, hospital bed, oxygen, all of the supplies, if we need dressings, Band-Aids, bandages, if we need briefs, we don't use the word diaper, we say briefs, and those are supplied, both the pull-up type and the tag type. And this afternoon, if you haven't been to the caregiving one, you get to put a brief on me and turn me and change the bed. So all of those supplies, if an individual needs a catheter, and we're going to talk more about that, all of those things are supplied. The shampoo and the all of that stuff. And then the bath aid will come 1 to 3 times a week, in kind of the middle end if people come later, within closer proximity to death. Of course, they're being seen more and get more services. The most services in hospice are at the beginning and the end.
I need a pen.
Oh, you do?
Or a thumb.
Oh, I'm sorry.
No, it's all right.
And then Windows and K together. That window and K together. I'm sorry, just keep touching it, playing with it.
And I don't know how to get off of that screen yet.
Okay, I don't think you care. Alright, it came up. It's coming.
I believe you.
It does, and online they can't really probably see these slides well anyway, I mean on video. Okay, let's get into it. Let's really get into it. Early signs of approaching death, and this is weeks to days. Okay, there are some that start a little bit earlier. Those actually include increased sleep. This is normal. It allows our guests to sleep in accordance with their own body rhythms. It's called natural awakening. Do we wake people at 8 o'clock for their meds? Well, this is interesting. You would think no, because I just said, there's some contradictions here. I just said, oh, but we let people have their own awakenings. However, you will see some of our medications, an order scheduled if it's a symptom management med. Like morphine is scheduled every 2 hours. The reason it would be scheduled instead of as needed is because the as needed wasn't working, and so people weren't maybe giving it or whatever. And so we do want to do that, because in pain management and other symptom management, if we stay ahead of the symptom with our medicine, we will use less medicine. You know, and nobody wants excess. And so it's kind of a little bit counterintuitive. When people say, well, I don't want it if I don't need it. Well, if they have it scheduled, it is a reason that they couldn't be managed without it. If it's as needed, of course, and they're comfortable sleeping, absolutely. Let's go ahead with our natural awakening.
Just checking. Still want to be in the class. Or do you want to do something else? You can continue.
Okay. I just want to tell you it's not personal. Okay. Okay. So then we come from, we talk about here, no need to wait for scheduled meds unless
You're learning this information. It's great.
decreased level of consciousness and turning inward, and this is a tough one. People sleeping more and more, and that's another one that can happen earlier on than weeks. And it's one of the actually one of the criteria for hospice is for many of the diagnoses is sleeping much more. Sometimes people are sleeping 22, 23 hours a day, and people become less aware of their surroundings. People may appear to be asleep with their eyes open, or they may not respond to that stimuli around them. Please understand that they can hear you, and so we need to, even if someone's completely unresponsive, we need to talk to people before we touch them. We don't just start opening the gown and changing them. And I know that seems common sense, but you think, oh, well, I know them and they must know what I'm doing and they hear my voice. Touch them gently and tell them what you're going to do regardless. This is a state also, if people have their eyes open, sometimes family members are sad because they don't understand why the eyes are open and they're not recognizing the wife or the son or whatever it is. And it's really hard for the families, especially when the eyes are open, because they're right there. Why aren't they? And why aren't they? It's because they're in a process of what we call is a very fancy professional word, but it's called turning inward. And it's a natural thing that happens. You know how if you, God forbid, are in a car accident and there's that saying, oh, their life passed before them. Well, this is that only when people are able to die naturally and not of a heart attack or an accident. Naturally, you have that life review that goes on. And so it's really a lovely thing, but it makes you less aware of your environment. It's not a conscious thing to do that. So we really need to let our families know he's not just turning away from me. You know, this is not a conscious process. May push others away physically or by expression, that's okay too. With us, again, difficult for families. When, you know, they've taken care of them all the time and then they're pushing away and needing space. There are many reasons for that, and the spiritual as well as physical, a need for all kinds of reasons, and so we also need to let the family know it's not their fault. What is another thing that's hard for families? When their person isn't eating their chocolate cake. I have been married to him for 70 years, and this Dutch chocolate, I don't even know if that's a thing. This chocolate cake is his favorite, all occasions. Why isn't he eating it? So we'll talk more about eating and drinking in just a few minutes, but that's another one that we really have to work with families to help them understand, and I'll go into the physiologic process of that. People can hear, feel, and see. People's tolerance and wish for presence may vary widely. And not just very widely among people, very widely within the same person as they get closer to death. They may become what's called tactily defensive. So yesterday I came up and I touched you on the arm before I talked to you, but today I can't tolerate it. So when we find something that an individual that does help them be comfortable or happy or calm, we write it in our book, and I'll show you that when we get to the books, to tell the next person, because if the person's not speaking. On the other hand, please note that the body is changing and the brain is changing, so it's not just because it worked the last 2 days, it may not work today. So that's where we just need to not make assumptions, and then make your note in the book. People may experience a rally. Let's go to, let me just show you, because we can't pull it up on the screen. We are going to, I'm going to show you a picture of this lady having a rally. And this lady is my mother. If I can find you, Mom. Mama, here she is. Oh. This is my mom. My mother was what we call actively dying. Okay, rally is not just the normal ups and downs and level of consciousness and stuff. A rally is when you are actually very close to death in the dying process. Maybe you're having periods of apnea, maybe just breathing, maybe a couple times a minute. Maybe your heart, you feel the pulse and it's weak and thready, haven't been responsive, maybe you haven't eaten or drunk for 4 or 5 days, and the person wakes up. This is very confusing for families. Oh my gosh, look, he's, and calling everyone to come from out of town, and by the time they get there, they're not in the rally anymore. And so, it can be confusing, but it's also a great last chance to have a convo. Sometimes they want to eat. This was my mom's rally. I don't know if you guys know the band The Roots from Jimmy Fallon. Is it Jimmy Fallon? And she loved The Roots. And for some reason, whatever she was watching on TV, she thought that it was The Roots getting some kind of a music award. And she was thrilled. And then she ate some Whitey's ice cream. It was her favorite. And then she died about 4 hours later. So a rally can last anywhere from an hour to even 24 hours. If it lasts longer than that, it's not a rally, and you think, oh good, we have their symptoms managed. Okay?
So we experienced that with our beloved uncle. Well, when he was dying, and he was always a man that was giving, a very giving man, a very peaceful man. And so when he was going through his death, he was at home, and we were all there from time to time with him to see how he was doing. That happened, and he was a very, he loved his church. He was very active in taking care of the church and everything. Well, it happened on a Sunday when he had this rally. Sunday morning, when he would have normally probably been getting ready for church, all of a sudden he was just, like you said, he was back. He was like, just like if he had just woke up, he was doing fine. The one thing that, like I said, he was a very giving man. We had been so concerned over the previous 3 or 4 days because he seemed like he was in so much pain, and we couldn't, we were giving him pain medication, but he would groan and moan and like he he seemed like he was in pain. So when he was awake and rallying, we asked him, well, he didn't know what was going on. We said, well, over the last few days, were you in a lot of pain? He goes, no. I said, you never hurting at all? No, I haven't had any pain. So that brought a lot of comfort to us.
Absolutely.
It let us know that he appeared to be hurting and we didn't know what we could do, but he said, no, I wasn't hurting at all.
Well, two interesting things about that. When people are moaning and groaning, they are having some discomfort. Whether it's breathing, there's a reason, or whether it's a bad dream, or whether it's, so we do treat those symptoms. However, because we are just now, in the last number of years, 20 years or something, learning what things really are the most distressing for individuals when they're dying. And you might imagine, because studies have to be validated, so it has to be a wide number of people and the same things repeated over and over. And we don't have a lot of people around the world even studying this, let alone a lot of people who happen to be entered in one of these studies and have a rally and can tell us. And so it's many, many years, but we are learning some things from that rally, and so that brought to my mind one of the things that over years has been validated is that one of the worst things is the dry mouth. People say that more than pain, and we know to use the sponge, and I'll talk about that. But it's interesting that we're getting better at managing some things, and then some of what we think are smaller things, we're not. So more to come, with the question that your comment begs is, were they really in distress? I think he was in distress. He may either not remember, it may not be pain. It may be emotional distress. A lot of older people don't describe emotional pain as pain. That's not the language. So thank you. That is a perfect example. Okay, decreased appetite. A normal part of the body shutting down is a decreased appetite. We do not force food. We do not. We offer food, and we offer fluids. We do not force food. And why is it that our appetite is less at the end of life? Well, of course, you're not active and all of those things, and that's earlier on. But as the body begins to shut down, all the systems, the organ systems begin to shut down. It isn't just one and then done. Yes, a heart attack, but that probably also involved other organs as well. So what the body does, let's talk about hunger. When you do get hungry, why are you hungry? Because those digestive juices are moving. Okay, you hear your stomach growl, and what does that mean? And you feel that emptiness. That occurs when the stomach is empty and ready to take food or beverages, whatever. If that is not occurring, we have to honor that, because what it means is the system's not ready. So you can cause nausea, vomiting, diarrhea, constipation, so many things. And if we put that food in there when the person doesn't want it. So we have to respect that. And what about, let's see where we are. I'll try to follow that. Okay, another thing about we honor their appetite. It goes the way that we don't force food. But let's say somebody wakes up at a rally, or somebody really, really just wants a piece of chocolate or a piece of pizza, but they can't swallow. They're not swallowing anymore, which is another sign the body is telling us that we shouldn't be putting food in. It's also muscular and neurological and dementia, but it's one of the reasons that we get difficulty swallowing is because our body's not ready. So what do we do if somebody is, pizza, what do you think you do? They can't swallow, they can't, any ideas?
I think even just smelling it would be.
Smelling, absolutely, and you could, thank you, you put maybe your finger in the sauce if you know that they like the sauce. Cheese is a little harder, but maybe you could ball it up and put it right here so that they can get the feel. That is exactly right. And, yeah, so it's never no, it's how. Okay, never no at the end of the day. How are we gonna do it? Okay, so don't force people, but also don't deprive people if they want it. Find a way, talk to your team, call Miles, call me, all of those things to get some ideas. So, as I talked about that here, well, difficulty swallowing, that's called dysphagia. If I don't know how much of the terminology is interesting to you, but just I like to share that with that word, there are two words, dysphasia with an S, dysphasia, that comes that's speaking, and so that is that has to do with a stroke. Dysphagia, or some people say dysphagia with a G, that's the one that has to do with swallowing. So it's the one with the G here, just in case you see those words and you're confused, it would make sense why you'd be confused. And when they're nothing by mouth, excellent mouth care is important, and I told you that we've learned, that's one of the things we've learned from research over time. The toothlets, the sponges on the stick, are great. They need to be repeated often. If a family member is here, sometimes families feel helpless, like they can't really do anything. And so it's a good thing to have them do, that you're not making it up just to make them feel useful. It's a thing, okay? And I do not ever recommend in end-of-life care lemon and glycerin swabs. Lemon and glycerin swabs actually will, in about 15 minutes, you will be drier than you were before because of the ascorbic acid. And so that's great for if I have my appendix out and I'm not able to eat yet after surgery, and and I can put it in my mouth, they're great. Because then you can put another one in 10 minutes and another one. With our folks, where we're providing the mouth care and people can't do it themselves, please use regular sponge on a stick. What do you put on the sponge on the stick?
Water.
Okay. Anyone else?
Says here, coffee, tea, or beer.
Okay. So, 6 in the morning, 5 in the morning, this guy was a farmer, got up, crack of dawn, and always had his black coffee. Because we're going to say what things you enjoy, and that's one of the things on the individual preference sheet that we have spaces for. If he wakes up in his normal previous pattern and it's 6 a.m., and his wife said, he never could do anything without his coffee. Put a little tiny bit of coffee. You're not going to put a lot, just like you wouldn't put a lot of water. But remember that tastes and smells are nostalgic. Taste just like smells. We all know smells. And so coffee does also have a distinctive smell. But put a little on. Another story about my mom taking care of her a friend in her condo building. And he was an architect, and he was a traditional family. His wife had died. My dad had died. He would come home like 5:30 and take off your tie. In those days, the kids were clean and waiting for you already, ready for dinner. Dinner's on the table. You are not stressed like you are at work. You can share angry or frustrating things that might have happened at work, or things that are not appropriate to share while you're on the job. So you're really letting down. And we know that Tom had a gin and tonic every single night at 5:30. And he would come to my mom's unit to have that. So in the last year or so, I knew it well because that's how I knew Tom when I visited. And I said, Mama, why don't you just take, it was about 5 o'clock, and she said, oh, I wish I could just make him a gin and tonic. I said, well, why can't you? Well, of course I can't. He can't swallow. I said, well, let's just have you make one. And gin and tonic, unfortunately, I don't like either one, but they're really good because they have such a strong taste as compared to like club soda and vodka or something. So you get a lot of memory out of just a little bit of a taste. So I told her to dip the sponge swab, not lemon glycerin, the plain one, and just put a little bit on his tongue. So, well, Libby, and I've already given him morphine. You told me to give him morphine. And I said, well, this is just a tiny touch. It doesn't have to do with intoxication. It has to do with what that means to Tom in that comfortable time of day and letting go. And she called me back after she did. She said, you're not going to believe me. And I said, what? She said, he smiled. I said, well, I do believe you because I wouldn't have told you to do it. Now, it isn't always effective. Sometimes people aren't. But of course I believed her. I'm not going to just, let's say, oh, tickle his toe and he'll raise his hand. You know, I didn't make this up, and it is a fact. So it doesn't matter if it's alcohol, it doesn't matter if it's coffee. If you are putting though something that's not water, like coffee, that later after you're done with your cup of coffee, so a few minutes later, once they've had their taste, then go ahead and swab it out with water. Some people say, oh well, does he like cold water? Do you think I should put ice or should I do it warm? A couple things about that. One, you can say, well, what did he usually drink? Oh, he always said no ice or easy ice. Okay, do that. But the other thing is that people change again, and so there is some trial and error. And once you, as I've said, once you get the right answer, it might change the next day. The other thing is that there is, and I have a slide that shows this, but it is the word kavanah. And kavanah is the Hebrew word for intent and care and doing the right things for the right reasons, or even the wrong things for the right reasons. I don't want someone to do the wrong thing, like, break someone's leg. I don't mean that. But if the intent is to love and care for our individuals, and maybe you put ice on his tongue and he flinches and he's like, makes a big noise, and then you feel guilty. It's about the intent, and that didn't hurt the person because you were there with love. That had no intent for harm, and you say, I'm sorry, next time I'll do such and such, and whatever they react to. If they're a touch person, rub their arm or whatever. If it's about the intent. One example is early on, before I was training, somebody who was medically trained, put in a cup crushed, and I'll talk about meds, crushed senna, which is a fiber laxative, in a cup with the morphine and with water, and tried to give it to the person. And it was not a good thing. And then they were putting things in jelly. Well, if they're not eating and drinking anything and not processing, that sugar can just live. They didn't know, and when they took the training, oh my God, it's okay. You did it with kavanah, with the good intent. So it means we want to learn as much as we can and do it the right way. But sometimes we don't know the right way until we try it, and it's the wrong way for that individual. So really important to keep that in your mind, that everybody here has the best intent. We all practice a little bit differently. And this is not a medical model. So we are functioning as the family. Hospice functions as the hospice organization coming into a person's home. Do families know everything to do? No. So I have found that because we seem like we're in assisted living or residential care, that hospices don't educate as much as at least than I and all of my employees have always done for families, because they think, oh, well, these people are trained, but we are not professional caregivers. And so don't expect that you'll know everything, ask questions. Yeah.
How do you spell that word, kavanah?
Oh, well, I'm going to tell you a way. It's in Hebrew, so like Hebrew or Chinese it's transliteration, so it's made up letters. Like you'll see Hanukkah spelled with a CH and 2 Ks and 1 K and no H, so I'm just going to tell you that I spell it, and you'll see it most of the time written in English, Kavanagh, and I'm sure I have a slide. I'll take a photo of the slide for you. I can't get. Okay, let's go to incontinence. talk first about the most extreme, and that's catheter. Why do people have catheters? Maybe they have urinary retention. Maybe they have a prostate problem. Maybe they have bladder cancer. Maybe they've just come from the hospital and the hospital is not big on changing a brief. The hospital will drop a catheter in the second you enter the door. And especially if you've been there for a stay. That is, they're there to heal you, not, I mean, they're there to comfort you, but not to, they do that. So that might be one reason. For convenience of staff. Even rectal tubes sometimes for convenience of staff. We don't put a catheter in end of life care, and we take it out if they don't want it, unless the person is retaining urine, and we'll talk about that when we talk about another end of life sign. If they have really terrible bed sores, and in the home we do it a lot if maybe the caregiver's elderly or has a disability and has trouble, or maybe the patient is really heavy and hard to turn, and they have terrible sores, bed sores, and they're made worse by urine. Then if agreed upon by the individual, if they're able to talk, or their family, will put it in that circumstance. We obviously don't have that here because we are happy to change, and that's what we're here for. So usually urinary retention, and it can be one of two things. It could be just an in and out catheter. I'm a fan of that. And the hospice nurse will tell you, you don't have to determine. But if they have no output, and you need to let the hospice know, and then they'll feel if there's distension, and all of that, they'll do their assessment. It's really nice at the end of life if we just do an in and out catheter, because we begin to stop. I say begin to stop, I'll explain when we get to that. Begin to stop making urine. And so this could be the last time. And to leave them with that tube, and if they're delirious, the preferred way, if we're very close to death, but we do need to relieve and give comfort, is an in and out catheter. There's no balloon blown up, it is night and day. I mean, no one likes, but it's night and day different than putting an indwelling catheter. However, we do have some people that have urinary retention or bladder cancer or whatever that might be, who will have a catheter for medical reasons. They come with it. What do we do with it? We will show you how to empty the bag. You are welcome to do pericare, and we'll talk about that when we do our hands-on care. You do not change the tubing. You do not take the catheter out. You do none of those things. But you can certainly, if you're comfortable, empty the bag. And that is kind of a comfort thing, because if it gets heavy, and especially if it's someone who's ambulatory or out of bed in a wheelchair, let's update. So we'll talk about that. Okay. We're gonna skip cleaning because we're gonna do that. Cessation of urine. So urine does often stop at the end of life, and it's called anuria. An or a is the prefix for not. And we used to think that everybody stopped having urine when they stopped eating and drinking. And we now know that in some people and in some circumstances, people do continue to be able to get rid of the waste that's already there, or the toxins or the fluid or whatever. And so we used to just assume that was why. Well, now we assess much more closely. And the hospice can do that for you, but we're the information givers when a hospice nurse comes in. And we're their eyes and ears. We now know that sometimes people really do fill up with urine and they haven't maybe eaten and drunk for 3 days. Maybe they've been retaining it all the time, whatever. So it's important, even though most people stop making urine, not everyone stops, and it's very uncomfortable. Same goes with stool. Well, he hasn't eaten in 3 days, of course he hasn't had a bowel movement. Well, yeah, and he's taking opioids for pain or shortness of breath. He may still have that stuff up there, and it's all constipated and stuck in there because we are not moving, you know, there's no, all of those things, that we're not eating, drinking, we're not moving, we're not, all those things. So, that stool may be there. And so once again, it is very important that we document people's bowel movements. There is, I don't always do the activity book because I write in the free-handed notes, I underline the meds, but in that book, very importantly, is if they've had a bowel movement. If the family stays here, like Lupita's lovely daughter Lorraine virtually lives here, and she prefers to do a lot of her mom's changing and stuff, doesn't always let us know because she wants to do that. She knows that we're absolutely, and when she does need help, she asks. And she said, well, the hospice nurse keeps asking me, and then, I don't know, one of the caregivers said, oh yeah, I've seen him have a bowel movement every day, and they had this person on a very aggressive bowel regime that maybe, and suppository, may or may not have needed. How would you know if they need it? Because they're going to err on the side of, how do you know if we haven't recorded it? And she said, and I said, well, there's a book, but it wasn't marked in the book. And she said, but you know, I don't have access to the book. I said, well, one, there's no reason you can't have access to the book. That's your own. But you certainly aren't expected to be reading it or writing. So I wonder if it's still on the wall. Yeah. I hung a sheet on the wall so that the daughter could also mark bowel movements, and we could, and it was complete. And they didn't have to go to our book. So we know that those are the two places that when the hospice nurse asks every time, and she or he should ask every time. If they don't, we need to tell them anyway, they should be asking. So you can do something like that. That was just a random thing I did in there, so we don't have a formal form. I wrote do some ridiculous looking flowers or something on the outside so it doesn't say, we are social, not medical. We don't really want bowel movement, you know, like in the hospital and there are all the signs, you know. So I kind of made it, you know, look a little fluffier. Sorry for that analogy. Okay. We'll talk more about the medications when we get to medications. Diarrhea also can happen, and for a variety of reasons. And so we want to note that as well. So if there's something unusual about the characteristic of someone's bowel movement, write it. You don't have to write, you know, it has, is anyone over there to help me answer this question? I can't think of the word for mucousy stool, but you don't have to know those things. Just write when you see it. It looked watery. It was loose. You know, whatever. And I don't want you to use any medical terminology at all, and I try not to myself in the book, because when people use jargon, that same jargon may not mean the same thing to two different people writing it. It also may not be understood by the reader, and we're writing for the next shift. So no jargon, including poop, but please do write the character if there's anything unusual, or you can write normal, just NML or something if you want, but if it's different, certainly do put that. And same with when people are wet. If you go into the room and it smells god awful, something you've never smelled before, typically we'll already know what I'm going to tell you, but everything stops and starts somewhere. You know, the brain has to start and stop somewhere. And so it may be that the person has C. diff, or Clostridium difficile, which is infectious, and it will cause a lot of stool, and you'll never forget the smell if you smelled it. I just know you'll know. But don't be afraid to ask someone if, you know, sometimes it just smells gross. And you're not sure if it's the gross or if it's just because that's normal stool smell. Don't be afraid, like, what if it's not and I'm so embarrassed? Just ask one of us. And because C. diff is, I think you guys had a module on infection control. C. diff, you will need gown and gloves, all of those things. I'm not going to teach you about the PPE because you will all, and you must be specifically trained the first time you take care of someone who's in isolation. The other thing that's very important is if you've just been in there and you realize it, and even if you've had gloves on, when you come out, we usually say use hand sanitizer, right? Hand sanitizer for 10 seconds is the most effective, except when it's C. diff, and then a couple other things that you'll never see. And so you must wash your hands with soap and water. You must always wash your hands when you change gloves, right? And so, unless you double glove and triple glove, but never in C. diff would you do that. I mean, you might double glove, but you wouldn't peel off one layer and have another layer. But normally, you can double or triple glove. If you're changing somebody, chances are you're going to get your hands dirty and they're going to get the individual dirty. So, since you have to clean your hands in between, a lot of times people will double or triple, and you'll kind of know because you've kind of, looked and checked it out before you get started. And so that is acceptable to peel off a layer of gloves. Once those gloves are gone and on your hands, before you put that next pair on, you have to hand sanitize. And a note about liver disease. So, whether it is, and by the way, cirrhosis of the liver does not only occur in people who have alcohol-related illness. We don't judge people here anyway, and if anyone does, they wouldn't be here anymore. However, still, in people's minds, they may have a judgment. And so I think it's important for you to know that cirrhosis of the liver can come from many causes. So, an end-stage liver disease and all of those things. So it could be cancer, hepatitis, it could be all kinds of things that are not related to anything that the individual did. Not needles, not... so we've got folks with end-stage liver disease. A few things about that. One is that the belly will often be big, and that's called ascites, and that's the fluid that builds up. And sometimes they'll have a drain to drain it. Hospice will either take care of that, or they'll teach us how, and you'll only do it when you're comfortable doing it, just like that checklist. You just be, go do it with an indwelling drain. But most people won't, and it's a godsend when they do. But it requires being in an operating room. We don't have any physicians that I know of anymore, providers who go to the person's home and actually do the procedure to put an indwelling or a staying tube in. So we wouldn't send someone back to the hospital for that. They elected not to do that. And so if they're already here and don't have it in, our jobs are several. One is to note that when people have any trouble breathing or when they have ascites, it pushes up on the diaphragm. So that really impacts their breathing. So positioning, whether that's head of the bed up, sometimes it's the head of the bed lower, depending on the individual, how you get that release, and get that fluid to, or that, because it's hard. It feels hard, because it's tense, taut. The other thing about the liver disease is that what happens is the liver is no longer making adequate platelets or other adequate things that we need. One of those is the platelets that are the blood clotters. So there is a risk that a person with end-stage liver disease might completely exsanguinate or bleed out. Typically it's a smaller stream or no stream, and it could be from any orifice. It's important that the family know, and this is hospice's responsibility, but it's good for you to know, that typically if that happens, especially if the bleeding is, everything, that is typically a good death because the person has slid into shock. But the good death is for the individual, the good death is not for the family. Okay, this can be years, and so I ask that every single time we have an individual who has liver disease, we put dark towels in the room, and we have dark towels, they need to go in the top drawer of the dresser, and you need to write it in the volunteer book that it's there, and you need to write it in your notes. And if you are taking care of someone you know is a liver patient, a liver person, don't assume they're there. Please look at the beginning of your shift. Okay, just make sure. It's sometimes overlooked, whatever. So, or can be. The reason for those is if family members there, or even volunteers. I mean, volunteers who aren't, I mean, it's upsetting for anyone, actually, honestly, except the patient. If you put those stuff, you have those towels, you know where they are, you grab them right away. Not go to the closet, and it's, you know, sometimes it's explosive. If you put them right away, if it's coming from the mouth, if it's coming from the rectum, wherever it's coming, put them at the site and put them on the floor. It looks completely different than it does when we have the white or floured or whatever, and the blood is coming out and it's pooling, and it's get those dark towels. So navy, black. I brought some black ones. I think we have navy and something else. Please always be sure that they're in there. And another thing about our liver patients is that the other thing that the liver does when it's healthy is it processes ammonia. And when the liver isn't functioning well, the ammonia is no longer being filtered out. And where does it go? It goes to the brain. And it's called hepatic encephalopathy. You don't have to remember that word, but that means liver, brain, swelling. What happens? That's what happens when the ammonia builds up. What happens when somebody has a swollen brain full of ammonia? They're delirious, psychotic, sometimes violent, agitated, all of those things. How do we manage that? Is with lactulose. There's one thing, and it is a greasy liquid, and people who can't swallow it can't take it. So I'll tell you what to do, because doesn't come in a concentrated form. But it tastes terrible. People at home, you'll find, are non-adherent with taking it because it's awful. And in order to bind with that ammonia, which is how it works, you really need to have like 5-6 big greasy stools a day. And no one really likes that either, especially if it's a younger, alcohol-related person, a guy who's, they don't want to smell and have greasy stools and drink this awful stuff. And so we may get the person in that state. If they can still swallow, we'll be giving them that lactulose. It binds. Please expect and know it's normal. You want those big greasy stools. That means the greasy lactulose is pulling out. You might see someone on lactulose that can swallow. Other than that, because it's also laxative. Nutrition, hydration. How are we? Does anyone need a break? It's been an hour. Everybody good? Okay. I mean, do feel free to get water or coffee or anything, even while I'm talking. Don't think you have to stay here looking at me. So a bit more about nutrition and hydration. Why would it not be the gold standard to put in a feeding tube or any kind of feeding tube, a peg tube, a tube, in the IV, however it's given, in the nose, or IV fluids and electrolytes? Why in the world will we not be giving that to someone who's not eating and drinking, So, you can go ahead.
I think, but that's again, the body's not processing and digesting, and it can't filter all that stuff out.
Bingo. So, let's say you're giving it, in the feeding tube, it's kind of like an Ensure or Boost or something, it's a formula. Sometimes they have a lot more nutrients even than that. And so just because we're giving it in a tube, if the GI system has slowed down, just like Nicole said, it can't process it. So you're still gonna cause nausea, vomiting, diarrhea, reflux, fluid retention, all of those things. It doesn't matter that how it's coming, the body's not processing it. And so that can definitely cause more problems. Will we ever have someone with a feeding tube? Yes. Lupita has a feeding tube. We're not using it to feed her through. But we keep it there because it's a really good way for her to keep her anti-seizure medicine, her Keppra, which doesn't come in a concentrated form, and she's not swallowing well. And so we can give it via that feeding tube. So, of course, we elected to leave it in, even though the family and we are not feeding her through it. And so that's one reason, and then there may be other reasons that people have them. So you'll see that. Sometimes you'll see people come in with an IV. We typically will go ahead and discontinue that, or we'll ask the EMS people who bring the person or the hospice person. And the hospice person should be meeting the individual within an hour or two of that individual's admission, when possible. Not really acceptable to not come till the next day or not have orders. We'll talk about that when we talk about meds. What about fluids? Oh my God, he's you can't leave him dehydrated. He's just gonna. Why wouldn't we give the IV of fluids if it's not food? Same reason. So you've got. First of all, it's going to increase those secretions, and we'll talk about what that is at the dining process. It also is going to, it's going to stick in those places in between the cells. Everything, that's usually all processed. It's not being processed, it's not moving. So then you're going to cause urinary retention or excess urine that you don't need to be turning and changing and risking the breakdown because the natural body, doesn't, that's not natural. And because if you allow your body to dehydrate naturally when your body says not to, either because you're unconscious, you can't swallow, you don't have an appetite, at the end of life, this is not talking about a 30-year-old having their appendix out. At the end of life, if you allow that to happen naturally, you release endorphins, and endorphins are those hormones that are natural pain relievers, mood elevators, and you rob the body of its natural response to that if you put things in that don't belong there. It doesn't mean we'll never do it, and there aren't exceptions. Everything I'm talking about, there are exceptions. So don't hold me to this, but the majority of the time. Okay, we talked a little bit about families being upset. Let's go to, if you sure no one needs a break, we can go to pain, which is a big one. All right. Pain is what the guest says it is. So, on the palliative unit at a particular government institution where I was the educator for a number of years, we had our provider was a nurse practitioner, an older guy, and he would insist, well, they don't look like they're in pain, and their vital signs are fine. First of all, with vital signs, when the pain is chronic and ongoing, it's not like you just fell off a tree. Your vital signs stabilize. Plus, our people's vital signs are not going to be necessarily normal anyway, or their behavior. Also, it doesn't matter what kind of pain it is, what the individual says it is. And he would repeatedly refuse to allow medication for people who maybe say their pain is an 8, and he said, right. Or they have, they have opioids in their history. That is not appropriate here or anywhere at the end of life care. First of all, we're not detoxing people. So if they do have dependence on opioids, we don't judge and make these decisions. We're not a rehab center, and neither is the hospice. They need more of the opioid for shortness of breath and for pain because they're tolerant. Okay, so that just doesn't. It is what the individual. What if it's psychic pain, emotional pain, energetic pain? Well, we need to consider that too, and we have all of that whole interdisciplinary team within the hospice team. And so maybe the person can't describe it, but they're experts at this and they know how to do this. Another thing about administering opiates, you'll learn that opioids are the treatment of choice for shortness of breath, labored breathing, gasping, not oxygen. The oxygen level's gonna go down no matter what you do. Person's dying. That doesn't make any difference. The only time that if someone comes in on oxygen because they have COPD, absolutely. And you know, we had one guy with a trach, of course you're gonna keep the oxygen on. But if it's as a result of the very end of life, due to the lungs and the neurologic system shutting down, some people like to throw oxygen on, some families like it. It doesn't hurt them except that it dries them out much more. And if they're delirious, feeling that on their face can be icky. We almost never would use a mask. It would always be cannula, and you'll see it as needed. But we don't do it based on we do it based on symptoms, not based on the oxygen saturation. You'll see we treat people here, not numbers, so you won't see us taking a lot of vital signs. You might see me feeling pulse. On if it's weak, thready, distant, if it's really rapid, you guys don't have to do that. But when I do it, I'm not counting it. It's just feeling. We treat the individual and how they look and are responding more than the others. So oxygen is not the first thing, but opiates, morphine, sometimes you'll see Dilaudid or others, are the first line of defense for shortness of breath. Why? It expands the musculature around the lungs, allows people to breathe better. And when the family says, "Oh no, he can't have morphine, you know, it'll kill him," and we get in hospice a lot of times we get ICU nurses who will say, "Oh, I can't give any morphine. His respirations are below 8." Well, yes, and they're going to continue to go down below 8, and the person will die. We know how to do this. This does not kill a person. Usually in the not hospice world, it is start low and go slow. Here we start low, but we can increase fast because we know what we're doing, and it's because we're gradually increasing, and tolerance is good. We want tolerance in this case because we want to be able to administer enough medication to make enough to manage this. What about you know, when people say it's addictive and all of that stuff? I think it's common sense. I don't like when people say, "Well, what, you think he's going to live another 10 years?" I mean, people say stuff like that. They really do. You know, here we're not concerned about it, and I more likely will explain that if you're getting the medicine as ordered and as it's needed and not using it recreationally, it's not a problem. I don't kind of go into the, "Well, that's stupid," because they're going to die tomorrow. You know, that's just not how we say it. But you'll hear that a lot. We also use methadone, and families will say, "But he didn't use heroin." Well, methadone is pain medication, it's not opioid, so we do it. And we'll talk more about the specific meds in the second session.
So we don't switch them from methadone to morphine?
Well, yes. And we'll do that when we're in the med room. We'll have a whole med room this afternoon. We'll be in there for an hour or more. So, yes, we do. Super good point.
Because there's a lot of confusion with Gerald about.
Oh, how well I know. That was our first patient, our first guest. And when I first shipped was Gerald's first night. Oh my God, and then as it went on, he was not managed well. It is partly because the hospices don't recognize that we are the family, we are not clinical caregivers. We are not professional, we are not trained, we are not training, but you know, we're not formally trained, we aren't certified, nothing. We are family. And so part of it was that, and so people didn't really know to speak up. And then I mean, part of it was honestly was the hospice themselves, and not. I don't know which one it was, and it doesn't matter. I mean, it did at the time because but we aren't here to throw anyone under the bus. It's common knowledge. It's about the intent. There were a variety of reasons people just didn't know. And so I'll talk about that more specifically.
Gerald was our first guest, and he was living on the street with tracheotomy.
Tracheostomy, yeah. Ostomy, because he has the
Yeah.
stoma, the whole, tracheotomy is just when they go in, tracheostomy is that indwelling thing, and he was shot 10 years before, in the throat, is why he had that. But, so he's somebody who was on oxygen because he had the trach. And he needed that. That was about something completely different than the dying process didn't cause it. So that's a great example on that hand. And then, the medications on another hand, but we were not giving him methadone for pain. I mean, he was already on it to maintain free of heroin. So I'll tell you more about that. So that's actually, we do use it for pain for people who have never been on methadone. And I'll tell you those, well, I'll just tell you right now, because actually we aren't going to go over methadone in there because it's just what's in the comfort kit. So I will tell you that methadone is often really effective for people who have either bone cancer or metastasis to the bone, giving NSAID like ibuprofen along with methadone is a great combination for that kind of pain. However, it doesn't come in a thoroughly concentrated form. So once somebody's not able to swallow well, you're not going to give them liquid morphine because it's too much to swallow. And then I'll talk about what David was alluding to when we get to the end, and that's very important. All right. Pre-medicating. If you know that somebody screams and moans when it's time to change them, I always use appendectomy. It doesn't have to be appendectomy. But you know when someone's changing someone or doing something uncomfortable in the hospital, drawing blood, whatever, and they'll go, and the scream comes up, it's okay honey, I'm almost done. It'll just be a minute, it won't take me long, I'll be careful. We don't do that. If the person dies 5 minutes later, they've died in pain. We stop what we are doing and we premedicate. And the next time, we know to go ahead and premedicate. Maybe it's anxiety. It doesn't have to be pain. Maybe it's shortness of breath because we put the bed down, because there's just one of us that makes it easier to turn and change when the head of the bed's down. It doesn't have to be pain medicine, but pre-medicate for whatever it is, and then note it in that book and in your notes that individual needs to be medicated, and I'll talk specifically about which meds have to be given in what time frame, how fast they work and stuff. So pre-medicate, don't stop and wait. There are a million non-pharmacologic things that need to happen in order to manage someone's pain and overall comfort. And so, as I talk about the medicines, you can read, and I have a handout, the Appendix A is suggestions for comfort care. And please read them, because there may be some that you didn't think of, but they'll be common sense. So I'm not going to focus on them. That doesn't need any tutelage, but I don't want you to think that the fact that I'm not going to go through them means they're any less important. So we always are doing our non-pharmacologic interventions as well. Pain meds like opioids in your left hand is your opioid, in your right hand is the laxative. Well, boy, oh boy. Maybe they're not making stool anymore. Maybe they can't swallow the laxatives. And we don't crush, we'll talk about crushing, we don't crush fiber things and put them in water because they get thieves. What we would do is, and this is also up to the hospice to give us orders. Most people will have an as needed, or PRN means as needed, order for bowel regime. So when they can no longer swallow, then if they are, and I have disimpacted many people at the end of life. It's up to the family whether they want that, because it's very distressing and uncomfortable. However, there's the most amazing relief, and it's most uncomfortable to have that stool backed up in there. And so, if you're 1 minute from death, probably not going to do it. But any further upstream, talk to the family, talk to the loved ones. And hospice is going to be doing this, not you, and decide whether we should give a suppository. I don't ever give enemas. I mean, some people do. It's a mess, and the person if the person can't swallow, we do think that there's stool in there. Based on what the hospice tells us, they're going to have us do a suppository instead of crushing those meds and all of that stuff. They'll have us do that, and sometimes they'll tell us an enema. Do you guys have to give suppositories or enemas? Nope. The hospice, and this is how it works in the home, is that the family, if they are able and comfortable, can give it. It's fine with the order on the phone of, give the suppository. So the same works here. If you're comfortable, I'm not going to call a hospice nurse at 3 in the morning to pop a suppository, and I'm probably on hundreds. But most of you guys may not be comfortable, and maybe it's cultural. Maybe it's a man is not comfortable with a woman. Whatever. You are not expected to do it, just like the family's not. If you've done it and you have a medical background and it's ordered and all things else, do it. If Miles is here, Miles can do it. Otherwise, call the hospice. It is their responsibility to do it if, like with a family, can't do it. So don't worry about it. I'm not going to teach you to give a suppository and an enema and all those things.
A suppository and enemas are they the same thing?
Oh, suppository is, and hopefully we've got someone with one in the cabinet there so I can show you when we get there. It's a suppository, and it's going to be either glycerin, which is just like oil, or it's going to be bisacodyl or a laxative medication in it. Both things help stimulate bowels, but obviously the laxative also helps movement. It's like skinnier, it's like my thumb and maybe stopping right here.
Okay.
And it has a kind of a curved end, and it goes in rectally. You wear gloves, obviously, you use lubricant, and you put it in. It seems terrible. I'm really good at it. I often don't need to actually turn, just my many years of home hospice, I don't even need to turn people a lot of the time because I can just pop it and use a lot of lube, and it's not nearly as onerous as it sounds. Enemas are. Enemas are that liquid, and they come pre-made now, and it's liquid, and it has a tube that goes in the rectum, and you squirt the water in. And often, especially at the very end of life, you can't retain it. That takes a lot of muscles. Remember, every system's shutting down. They can't retain it, and so it comes back out, and it's messy, and it's uncomfortable, and whatever. But there are cases where it's important to do that. There are some medicines we give as an enema. I mean, not in hospice, but in other. So I don't mean to say that they're bad. Everything I say, I want you to know that it is only in these circumstances, that it's not the greatest. But they can. Sometimes hospice will give an enema. And it used to be, we used to call it high, hot, and hell of a lot. I started undergraduate in 1979, so I've been a nurse for a few days. And we still had, it was a glass bottle, and then you hung it, and then there was a tube that went in. It was either soap suds or hot water and oil. And so this is, as I say, it's not my favorite at end of life. It is much, much more comfortable. So sometimes you'll have an older guest or family member who will say, "Oh God, no! I remember when they gave me that before. They used to do that before you had babies. They didn't want to clean up a little poop." So, oh no, I don't want that. Make sure you're telling them what it is. And actually, that's the hospice's job. But it's now compacted, smaller. Okay. Stay ahead of the pain. It is proven that if you stay ahead of the pain instead of waiting till the pain is severe, you'll use less medication. I think I already alluded to that. So running to catch up with the pain, not the way to go. Not the way to go. Other pain things that we won't go through in the med room. If the person's still swallowing, you might see anticonvulsants like gabapentin or what's Lyrica? Pregabalin, some of those medications that are anti-seizure medicines, even Tegretol, you'll see some of those medications used for pain. We're gonna be switching out, which is what I'll talk to you about in the bedroom. But you'll see some of the things and go, wait, I thought they took that for seizures. But we do use that for neuropathic pain or pain. Well, I'm not gonna go into that too specifically, but you will see that. You will also see tricyclic antidepressants. So not so much Prozac, not so much your SSRIs or SNRIs. More often you're gonna see the old amitriptyline is one of the main ones that you're gonna see for neuropathic pain. And you say, well, I don't have depression. Well, it's also used for neuropathic pain, so you don't have to have depression. And that actually, some of them can be crushed, some can't, but that's not the ideal once people can't swallow. But people with back injuries and those kinds of things are, tumors pressing on the nerve, you may see them on that and wonder why, because they have many uses. You ready to move to anxiety and restlessness, or you need a break? Everybody on board? All right, gosh, you guys.
Just soak it all up.
Okay. Anxiety, restlessness, delirium, and agitation. Is anxiety the same thing as delirium or psychosis? Mm-mm. Then should we treat it the same? Okay. Very good. Good on you. And I will tell you, this is a problem, even in hospice specialty, palliative specialty, that we treat with the glucagon medication. So, for the camera, I was just checking to see who's here. Anxiety is the feeling of anxiety, nervousness, fear, those kinds of feelings. Delirium, which is a sign of approaching death, is unreal thoughts. So, yelling things that don't make sense, being frightened, not like as in, oh, I'm worried about my wife, and how she's going to survive, like being currently frightened. It is psychosis. So when someone is agitated and screaming and pointing at things, they're likely delirious, having unreal thoughts. And so that is the difference. And a lot of times it'll be hallucinations. It will be what we call taco hallucinations, for when bugs are crawling, and hearing voices, the whole gamut. That does bring me to one other question, and that is, when somebody is reaching up to the sky saying, whatever it is, oh Lord Jesus, I'm ready, coming home, but you don't see Jesus there, or whatever it might be. If someone is seeing Tilly, wife Tilly in the chair, I'm going to be with you soon, Tilly, I'm coming. Are those things, is that real thought or unreal thought?
It's an unreal thought, but it's not delirium. It's
Well, you don't know that. We don't know.
It's real to
The answer is, we don't know and we don't care. We're not God, we can't, there's no way that we know this. And both camps feel strongly about it. The religious camp says, well, because people of all faiths raise their hands, that means that there is a presence of Jesus, putting his hand down. Even if you didn't believe in Jesus. Scientists believe it's the brain, because the brain and the neurologic system, as we've discussed, is shutting down along with the rest of the organ systems. So, we don't know. The answer to whether or not we treat it, though, is whether it's comforting or frightening. The same mechanism that causes people to reach up is also the thing that thinks the devil is coming and pulling them down, or Satan, or those kinds of things. And often that's a spiritual thing. Maybe, we saw a lot in veterans, maybe somebody who's been an abuser, done something bad, and they'll believe that there's hell and so we do treat that. We treat it with an antipsychotic, but what else do? We call the hospice because that also can be helped with chaplaincy and social work. Even if they're not talking, don't worry. Give them the medication so they can respond to the person. They know this is a whole specialty. They know what they're doing and how to help people even if they're not able to speak. So we treat delirium or whatever it is if it's not comforting and it's scary. What about if they're anxious and restless and just moving around and really can't sleep? So that's not delirium. So what we're treating the delirium with is Haldol or an antipsychotic, haloperidol. And we're going to go through that in the med room. It is in the comfort care. When the person's anxious, that's when you use your Ativan, your lorazepam, your Klonopin, clonazepam. You're going to use those benzodiazepines to help with anxiety. What if you're giving that Ativan, and it says you can go up to every hour, and sometimes we do need to give that much at the end, and you keep giving it, and they keep getting crazier and crazier. But they're not, they're getting crazier, but you didn't identify early, maybe you should have, that they were agitated, and which indicates delirium. And maybe they weren't. The reason is because benzodiazepines, those anxiety medications like Klonopin, clonazepam, and lorazepam, can cause delirium in the frail and elderly. So it's very appropriate for anxiety, and sometimes a good adjunct to the opiate for shortness of breath, at least the anxiety around shortness of breath. But you don't just keep giving it if they're more agitated. Once they're more agitated, they're delirious. We give the antipsychotic, we give Haldol. Anxiety does not help delirium, unreal thoughts, crawling, people screaming. It doesn't treat that. So we need to use the Haldol. If it starts out just as an anxiety and then it keeps getting worse the more you give them, you will then assume that this person is vulnerable and is experiencing delirium from that benzodiazepine. Go to the Haldol, tell Miles to call the hospice. I will tell the story of one Monday. I think it was my first, I'm pretty sure it was my first training here. And I was back and forth to Iowa when my sister was dying in a hospital. It was a terrible place to die. And on a med-surg unit, and I could not get a palliative consult until like the following Monday, which was 7 days later. And of course they had a catheter in. Of course they were sticking the suction down her throat. Of course they had oxygen. She was floridly delirious. She thought there were children running around on her bed trying to kill her. She was pulling out she had her legs wide open and pulling out her catheter. She was clearly psychotic. And they just kept giving her more and more Xanax. They did not give her the antipsychotic until I got her into a hospice house where she died. Well, I came home to teach that class. I came home that Sunday night. She died because we put her there. She was able to move there. People came on a Sunday night. She died once she was comfortable. She died at 5 in the morning. I was already back here, so I taught the class, and then zipped back to Iowa. But the point is, even people who are medical people, and actually, the book that you have, the booklet that I had printed at Kinko's, I had printed while I was in Cedar Rapids. I was still working on stuff, and I tried to give it to the staff, and they were just furious. They didn't want to hear it. They knew what to do. The attending was an internal medicine doc. He knew what he was doing, and so please know that even trained people sometimes don't realize this. So you're not going to be making those final decisions, but I think it's really important for you to know. And that's just as needed, and the person's agitated, and seeing things you'll know that will be your decision if it's just as needed. So go ahead and go to the HALDOL. If you're uncomfortable, call us. Call the hospice. Nobody cares. I don't mean no one cares. They care about you. They don't care. They don't mind, I should say. All right.
And both of those are PRN, lorazepam, and
Not always.
but can be.
They are
So
usually
we might be
PRN.
in the position of having to figure out which one
Absolutely.
to use.
Yep, and we're gonna talk about that, or when I talk about the comfort kit, actually in the room, so you can see what's in there and you can see how to administer it. We'll talk more about that. But let me talk about a variety of causes for anxiety and for restlessness. Remember I said, probably 10 times already, the brain and neurologic system is shutting down just like the rest. It's kind of like a domino effect. Effects of medications. Like, guess what? Ativan. A naturally occurring electrolyte balance, that thing that we want because that's the natural way of the body's being able to produce those endorphins. But it can also cause anxiety or sometimes muscle twitching and even delirium. Unfinished business, huge. And that can be anxiety or delirium. It can grow into delirium. Trauma history. Remember I talked about that turning inward and the kind of life review that people go through, or maybe, a lot of times the hospice will be documenting for the individual if they want kind of their life review written down and that kind of thing, or doing a video, audio diary. As that happens, all those things that may have been compartmentalized, as again, veterans, people or victims of trauma, people who have perpetrated trauma, and a variety of other things. Those things may come to the fore when the natural tendency, although this doesn't always happen, that's what, PTSD, but is to compartmentalize. You gotta go on with your life. Well, you're doing this life review where you're lying there and it's unconscious, and whatever it is, be it, Vietnam, be it stepfather molesting you, whatever, that may not have come to the fore before until that natural turning inward at the very end of life. So that is definitely one of the things that can happen. Sometimes a person visiting will trigger not just anxiety or anger, but delirium, depending on what that relationship has been. That brings me to, but we're not going to talk a lot about grief and loss today, but when it comes to people, our families, our loved ones that we have here, when their loved one dies, when our guest dies, you would think that if they had the best relationship in the world and were close best friends, that would be the hardest because they'll miss them every single day. People who hate their, mother because they, forced them to do something, sent them to somewhere, awful relationship. You would think people would be glad that they were dead. That is almost never the case. That is what we call complicated grief. When it's a complicated relationship, the grief is going to be complicated. So those kinds of relationships actually put the individuals at higher bereavement risk than people who had the great relationship. And it's also harder to manage. So that's where we really want to, hospice should be assessing that. And there's a number they give, 1 to 5, bereavement risk, and they should be following up on that. But sometimes they don't know it until we hear something or someone tells us something. So we really need to be on top of that and let them know. Interventions, okay. These are just a few of these. We're not going to talk, like I said, about all the non-pharmacologic interventions, but here this is really important when it comes to delirium and even anxiety. I have noticed, and I want to be very respectful of the practice of candles in a Catholic individual's room. I know that it's very important. I am not Catholic, but I know that it's very important. So I noticed when I was sitting with Lupita one night, she usually likes the TV on and the light out. this night she had the light off. She was sleeping soundly, and I see all of these shadows on the. And I moved the candle, but I didn't put it out. But you could still see the things that they were, and I left a note for Miles saying, I want to be respectful as I can be, so I didn't blow it out. But please remember that shadows on the wall are a huge trigger for delirium. So if you have someone who's delirious, look at that. One thing that's really common is if people's blinds are open during the day and there's a tree and it's blowing, what does that do on the ground? And if they're blinds, it makes an even funnier shadow. These are huge triggers for people whose brains are shutting down. So please look at your environment. And what your environment looks like at 1 p.m. is not going to look the same at 4 p.m. Okay, really pay attention to looking around. The other night there was a family leaving. I know they were getting ready to leave. We walked by, and I thought they were outside. I didn't see them, but I saw their shadow. So, and I said, oh my God, there's someone outside. And then I said, oh my God, it's you guys, duh. So really, really look. I had an art teacher that said, don't draw what you see, don't draw what you think you see. So pay attention and see what these things are. Just be very, and by the way, if your individual is ambulatory, this is sort of an aside with dementia. We don't like, for example, on a dementia unit or in a nursing facility, sometimes they have like wood patterns that are like a darker wood circle and all of those things. It is very common to terrify an individual with dementia by having those because it appears to be a hole. And you can do all you want. Oh no, Maddie, it's just the floor. So they see a hole. If you see a pillow, and I said, come on, man, that's a purse. That's not going to change your mind that it's a pillow. They believe it's a hole. So always looking at that with our ambulatory folks, if they either have some delirium or are end-stage dementia folks. Most of them will not be walking, but just in case. Bye, love.
Well, I didn't want to speak because I thought.
That's okay. We're saying bye to Rosa. We love Rosa.
Bye.
Okay. TV sounds. Hospitals love. I sound like I hate hospitals and nursing homes. I don't hate them at all. I just hate them for this particular purpose because that's not where people belong when they're dying. And they like to put on like soap operas and stuff. And so it's very important, when the person is not responding. Very important we ask people what they like on that sheet. If I hear the Big O commercial, Big O, the place to go, if that's the last thing I hear, I will kill myself if I am not already dead. I don't want to hear it. I don't want to hear The Price is Right. Some people love that. Ding, 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 ding. So it's very individual, and we need to know what they like or don't like. Also to remember that their preferences are going to change as the days go by. So really know if they want the TV, no TV. If they do, then they want, my mom wanted Chicago Bulls on the entire time. In fact, on the NBA channel, it played the same game over and over again, and they won. But she thought it was different games, and so it occupied her for a long time. But only if you see that it's either calming or comforting. It can also be terrifying. Lupita likes these terrible, scary movies with guns and like all the spy stuff. I was kind of scared, but she loves that. And when she'd wake up and look, she'd kind of smile, she'd kind of follow it. So we really need to understand, and then we really need to watch the person. The other thing, though, the same with music. We don't assume that everybody who is in Vietnam likes, my era of music, because sometimes those things are triggers.